Therapy Hour, NPR Radio, take one.
Hi, this is Kelly, and I have chronic migraine. I'm having one right now, and
It's more common in households across the U.S. without any concern for age, gender,
it's really hard
or
to
race.
describe what a migraine feels like. It feels I have stabbing pain.
In the U.S.,
Or
more than 37 million people suffer from migraines. Some migraine studies estimate that 13% of adults in the U.S. have migraines, and 2 to 3 million migraine sufferers are chronic.
It's harder to think.
Almost 5 million in the U.S. experience at least one migraine attack per month, and more than 11 million blame migraines for causing moderate to severe disability.
And I have to lay in bed in here.
For those of us who have never known the feeling of being so affected,
Lifting up my head.
what is it like to experience it?
I get so nauseous.
How well do we understand this population and what they go through?
Sorry, it's so hard to think. But
I do. You know I do.
A migraine isn't just a bad headache. So using virtual reality...
In a virtual reality experiment sponsored by Excedrin Migraine, dubbed the Migraine Experience, non-migraine headaches of volunteers were given a glimpse.
One eye. That's exactly what it looks like.
and challenged our volunteers to take on their migraine in a regular day.
By putting on virtual reality
never know when a
goggles,
migraine's
they were
going to
able to
come
experience
on.
emulated
And
symptoms
instead
of a
losing
migraine
vision.
headache,
The worst part is feeling off kilter.
and the
Any
volunteers
sort of bright
couldn't
light
handle it.
will make me feel like the room is spinning.
I start to see little dots, pops of light here and there.
The second that the auras start, everything else stops.
Oh, this is so crazy. Oh my goodness.
Wow.
Oh.
I gotta stop that.
Are you okay?
And the end result? Empathy and understanding.
I'm so sorry, Annie, that you go through this.
Okay. Oh my God.
You alright?
Oh my God. I don't even know how you function.
It's exactly what you just experienced, plus severe pain.
I'm sorry that I ever doubted you.
I
You
completely
believe me now, right?
I have your back for sure.
Fortunately, there's help. Neurology medicine. A neurologist is a medical doctor who specializes in treating diseases of the nervous system. The nervous system is made up of two parts, the central and the peripheral nervous systems. Illnesses, disorders, and injuries that involve the nervous system often require a neurologist's management and treatment. Headaches are complex. With many possible causes and treatments, they occur on a wide platform of conditions, from sleep disorders, post-concussion syndrome, and stress disorders. Let's investigate a little deeper into the phenomenon of migraine headaches, specifically how the field of neurology and neurology medicine describes and treats migraine headaches on this hour of the Therapy Hour. You're listening to the Therapy Hour.
A professional counselor in the Dallas area is growing in popularity for his treatment methods.
How do you talk to kids about terror? And with social media and television, it's everywhere, and it's unavoidable for kids.
Rusty Lozano is the founder of the Center for Biofeedback and Behavior Therapy. He's also been nationally recognized for his work with brain mapping.
He's created a gym to work out the mind. His office features an obstacle course.
Rusty Lozano is a licensed professional counselor, helping children with headaches, with anxiety, ADHD, and more.
Here's where Lozano comes in. He teaches kids how to think their pain away with something called biofeedback.
A North Texas therapist is treating patients in this unconventional way.
We have Rusty Lozano who's joining us today. He's a licensed professional counselor.
He put together an unusual treatment for teenagers who are struggling with mental issues, except he's taking this now a step further.
Rusty Lozano, a leading therapist and pediatric biofeedback therapist based in Texas at the Center for Biofeedback and Behavior Therapy. And Rusty, thanks for being with us tonight.
Rusty Lozano, a father of 4 and also a professional counselor in Texas, says it's all about being a credible resource to your children.
The Therapy Hour with Rusty Lozano, your dedicated resource for mental health news, views, and tips you can use. Brought to you by the Center for Biofeedback and Behavior Therapy in Addison, Texas. And now, here's Rusty.
Hi, and welcome to the show. We're talking about migraine headaches today. A big topic, and one that we've discussed in the past, and I bet that we all know someone who struggles with migraine headaches. My wife and daughter, for starters, they do. Let's look into the elusive nature of migraine headaches and treatment options. That's what we'll do this hour. We'll look at migraine so closely that we'll discover new things about it, new treatments. This is the Therapy Hour. I'm Rusty Lozano. My guest for the next hour is Dr. Amy Garza, who will help me sort through facts and fictions and treatment options for migraine headaches. She's the medical director of the Center for Neurology and Neurophysiology. How are you, ma'am?
I'm well, thank you.
Awesome. Well, what did you think about listening to that Excedrin migraine experience? So virtual reality and seeing how well virtual reality actually, can give somebody or emulate the symptoms of a migraine.
I thought it was a very interesting experiment. Many of our patients have similar conflicts with their family because if you've not experienced a migraine in the past, then you really have no concept of what it is to have one.
And I think that's it. They can give somebody the experience of what flashing lights and maybe the vertigo, but what's missing from that? It seems like they really do a good job of demonstrating the effects of it, but the component that's missing is pain.
Oh, absolutely. So the one thing about migraine headaches is they're disabling, while other types of headaches, like tension headaches, they may be painful and annoying, but they're not necessarily disabling. And so that's one of the important things about migraine that people don't understand if you haven't had one.
And the other thing is that you really can't tell by looking at somebody. They look whole and normal. So when they're doing their best to mask the symptoms, it doesn't necessarily mean that they're okay. I mean, I've had teachers in the past even look at my own daughter who struggles with migraines, and she won't listen to me when I'm trying to help her with treatment, by the way. That's a double whammy.
Of course.
But They look at her and say, well, she looks fine. She looks like she's able and she's groomed. So what's the big deal? But that's really not the case. I mean, you can't really what these people go through is very different, and the pain levels are unlike anything that we can ever really describe, or if you haven't ever experienced it.
I think one thing to understand, too, is, migraine attacks are very variable even in the same person. So some might not be disabling all the time, but then they will have a headache that is disabling. And, all of our patients that have true migraine headaches are neurologically intact, meaning, their speech, their vision, everything is normal in between attacks. But during the attack is when they're not able to function normally.
And that's when it's unpredictable. You never know when it's going to happen. Well, let's switch gears towards our agenda today. Dr. Garza, describe to us what is a migraine.
So migraine is a brain disorder. So there are changes in the brain that can bring on a migraine. We know that there's some genetics involved, that greater than 70% of patients that have migraine have a family history. we haven't identified the gene for the most common types of migraines, although we have identified the genes in rarer types like hemiplegic migraine. So we know there's a difference in the brain in people who have migraine and who don't. That difference, we think, increases the hypersensitivity. And so patients with migraine are more sensitive to light and sound and touch, particularly during a migraine attack. A migraine, though, as you mentioned, is a very disabling headache, so typically has a very severe quality. Often it'll be one-sided, we call that unilateral, and it will have a pulsing feeling to it. Some people will experience nausea, others nausea and vomiting, sensitivity to light and sound, and most migraine headaches are long in duration, so they last greater than 4 hours, usually up to 72 hours.
Oh, that's awful with a pain condition. And there's even procedures that they have, like an emergency procedure where they can be hospitalized and have a treatment like DHE, which in intravenous, medications, they will not, I guess, like use the IV to send the medicine directly into the bloodstream.
Right. So our goal as physicians is to help people manage the headaches at home. So we try to find effective abortive medicines for headache relief that will knock out the headache quickly. But certainly there are times when the headache won't break with home treatment, and we have to put them in the hospital or the ER and treat them with IV medicines. Particularly DHE can be one of those medicines that we use for intractable headaches. That's
just to kind of demonstrate that it can get really awful.
Absolutely.
You're talking about just taking daily pills to being inoperable and in your bed to then having to be rushed to the emergency room.
Yes.
So that's a wide variety of elements. Do we know what causes migraines?
As I mentioned, we know that it is a genetic condition. Beyond that, it's a very complex process that happens in the brain. Part of it is related to changes in the neurochemicals, neurotransmitters. Part of it's related to changes in blood vessels. And we know that a particular part of the brain called the trigeminal ganglion in the brainstem takes on that process. We don't completely understand every part of migraine yet, but there's a lot of research going into figuring out why. And hopefully we can have better treatments targeted at migraine.
Are they pretty common, migraines?
They're very common. I think 1 in 4 households has a family member who has migraines.
That's a lot. That's quite a bit. And it's not necessarily, I guess, is it inherited? Is that why something like that would happen, or is that fair to say?
Yeah, we do think that it is an inherited condition in most migraine patients.
Do you ever need an MRI scan to check if is it needed?
It depends on the situation. So if you have a long history of migraine-type headaches and you have a normal neurological exam, then it may not be needed, but it is often used to rule out other conditions. So when we talk about headaches, we talk about primary headaches. So those are your migraine headaches and tension headaches. And what that means is there isn't a condition that is causing that headache. It's the brain itself. With secondary headaches, though, those can be due to tumors, masses, blood clots. And that's usually what imaging is used to exclude those. But those are found in the minority of patients.
My guest today, Dr. Garza from the Neurology and Neurophysiology Clinic in Dallas. More from her after this quick break. Be right back.
You're listening to the Therapy Hour with Rusty Lozano, brought to you by the Center for Biofeedback and Behavior Therapy in Addison, Texas.
Welcome back. Our guest today is Dr. Garza from the Center for Neurology and Neurophysiology. We're discussing migraine headaches. In the first segment, we covered the definition of migraine and a few of the different types of elements of the migraine. In this segment, I'd like to discuss more specifics on migraine headaches, such as types and expectations. Dr. Garza, are there different types of migraines?
There are different types of migraines. The common migraines that we see are migraine without aura and migraine with aura. And what aura is, it's symptoms that precede the migraine of neurological symptoms like zigzag lines or blurry vision or bright spots are the more common types of aura, but it can be any kind of neurological symptoms, numbness, tingling, dizziness. Some people get the migraine without that aura phase. And so, those are the two most common types, but then we have rarer types of migraines where you can get just loss of vision or you can get weakness on one side. We call hemiplegic migraine. So there are definitely different types.
So hearing you describe these things and how it messes with even the sensors in the brain, sensors in the body, if you're seeing flashes in the eyes, aura effect, I mean, it really does sound like migraines are a neurological disorder. It's in the brain.
Right, it is a brain disorder. The interesting thing about migraines is we often talk about the pain, because that's what patients complain about the most. But really, we know there are several phases. So even before the aura phase, there's the prodromal phase. So some patients will have irritability, anxiety, restlessness, yawning, food cravings, even 24 hours before the aura phase. And then the aura phase,
oh, wow.
and some people...
It's like almost a little seismic before.
Mm-hmm.
Do you think people have learned to pick up on that?
I think some people have. Others, it's a little harder to pick up those subtle changes.
Mm-hmm.
But that is, something that precedes the actual pain of the headache. And so I think it's kind of simplistic to say that migraines are headaches. I really think they're more like syndromes.
Yes, absolutely. I mean, it's so encompassing of the different types of symptoms and like how the sensors are affected in your body.
Right.
Is there any chance that a migraine symptom might just kind of go away in a few years? I mean, is that hopeful to say? Or?
So people's headaches will get better over time, especially women. Sometimes after menopause, then the headaches tend to improve. But in general, it's a chronic condition. So just like high blood pressure and diabetes, most patients have it for a long time.
Right. And can it be managed relatively well?
It can be. As we talked about, there's a lot of variability in migraines, not only in the migraine attacks that each person suffers, but across the population too. So there are some people who have migraines once or twice a month. But then there are patients that have headaches most days. And so you have to tailor the different treatments to that person.
Do salts and seasonings, caffeine and things like that have an effect on migraines?
So there's triggers. Every person may or may not have triggers.
Mm-hmm.
If you can identify triggers, then you can reduce those, and that might reduce the frequency of the headaches. And common triggers are like chocolate, red wine.
Like the tannins and the caffeines.
Mm-hmm, yeah.
How does caffeine affect the headache, though?
So caffeine is funny. So caffeine is a vasoconstrictor. So oftentimes when you have a headache, caffeine will work in the moment because it reduces those blood vessels.
Interesting.
However, if you drink caffeine a lot, if you drink it on a daily basis...
Even when you don't have a headache, right?
Then it becomes like an overuse problem. So your body gets used to that caffeine load, and then you stop drinking caffeine, then you'll get a withdrawal headache. So in general, we recommend moderate caffeine intake. Try to limit it to 2 or 3 times a week, less than 200 milligrams, so that you don't get that overuse.
So you can actually pick a fight with a headache by drinking caffeine. You're just saying, what I hear you saying is...
Right, with overuse. In moderation, it's probably okay, but with overuse.
Well, how did the tannins in a wine affect a headache? Just curious.
Tannins, it depends. Some people will. Like I said, not everybody has a trigger, but, certain things make the brain more sensitive to migraines. And everybody doesn't have the same trigger. That's the important thing. What might trigger a headache in one person may not trigger a headache in another.
I had somewhere in here to ask about barometric pressure, and I want to understand that. I mean, what exactly does that mean? Atmospheric pressure and the effects on a headache?
Yeah, so barometric pressure refers to the pressure that's applied to your body through the air. And in the skull, we have sinus cavities, and sinus cavities are filled with air. So when the pressure changes, the pressure in the sinus cavities change. So all the things that we're talking about, tannins and chocolate and barometric pressure, they're not what causes a migraine. What they do is they increase the risk for a migraine.
So seasonal elements, I guess, we're actually moving from one time of the year to the other. Last Monday it was 12 degrees, and today it's like 70.
Right.
And I'm sure that has a play date with people who have barometric sensitivities.
Right. People are very sensitive. Migraine patients are sensitive to change. So even just changes in sleep patterns. We talk about sleep being very important in managing migraines, and it really has to do more with consistent sleep schedules. So some people will get a migraine if they sleep too little, but some people will get a migraine if they sleep too much. So being consistent with sleep, with diet, with making sure that they're drinking plenty of water throughout the day, all these things help reduce the risk of a headache.
And that sounds like you're kind of like indicating maybe a little bit of a lifestyle element there.
Yeah, a
alluding to it.
Yes.
So there are things you can definitely do to help yourself. It's not all about taking the meds, but the patient has to take some responsibility
Correct.
too.
Right. The medications are helpful and other treatments are helpful, but if you really want to manage your migraines, well, you have to do both. You have to do lifestyle modification. So, exercise is one of the best things you can do to help prevent migraines.
Yes. And we're going to get into that. My guest today, Dr. Garza, is from the Center for Neurology and Neurophysiology. More from her right after we take a quick break.
You're listening to the Therapy Hour with Rusty Lozano, brought to you by the Center for Biofeedback and Behavior Therapy in Addison, Texas.
Welcome back. Our guest today is Dr. Garza, and she is from the Center for Neurology and Neurophysiology in Frisco, Texas. We're discussing migraine headaches. In the second segment, we covered the specifics of migraine. In this segment, I'd like to discuss occupational detriment, or the effects on occupational function, going to work, going to school, things like that. So, Dr. Garza, in the Excedrin migraine experience that we were listening to earlier, we watched volunteers put on virtual reality goggles as a controller, emulated effects of light sensitivity, vertigo, blurred vision, and then we saw how friends and family members were apologetic and empathic to the migraine sufferer. Do you think that there's a tendency in schools, offices and homes across the country to minimize a migraine's symptoms because they look normal?
I think there is at times. As we talked about a little bit earlier, because the patient looks normal in between attacks, you don't associate the migraine necessarily being a disabling condition. But during a migraine attack, when you can't face the light, you can't, see well, sound bothers you, and you're in pain, it's very hard to go about your day-to-day activities.
Yeah, so when a person misses a lot of school, I know there's truancy. Say, for example, if you miss a certain amount of school days in a year, you can get in legal trouble. A parent can get in legal trouble. But if a child is actually having like detrimental symptoms and they can't think straight and they're in a lot of pain and they're crying, they can't get out of bed, I mean, what do we do about that?
So you have to work with your school, your counselors, and the people available to you, and your doctor, to create the conditions that would make it easier for your child to be successful. The other key part of that, I think, is making sure you develop a good relationship with your doctor. One, so they're aware of the situation, and two, so that they can work to manage the headaches better. And the goal of, as a neurologist, is to return people back to their normal life. Like I said, most people are not cured for migraine, but it can be managed so that when you do experience a headache, that it can hopefully be treated quickly. The headache can be aborted by that treatment, and you can go on with your daily life. And if you're experiencing frequent headaches, then it's important to try other techniques we call preventative techniques to reduce how often the headaches are coming. So it takes both. It takes working with your school officials as well as with your physician and keeping that open line of communication.
I've heard of some school systems that are a little bit less flexible with absenteeisms and being able to reduce caseloads for a child going back to school. And I know in a 504 accommodations, part of what we're trying to do is help these kids learn to have a facilitation to return to school, because otherwise, I have a program here at our center called the Return to School Program. Mm-hmm. And when a child has been out with symptoms for a substantial amount of time, they have a pile of homework like this. Well, what initially kept them from going to school was the headache, but then what ends up happening is what's keeping them from going to school now is like all that work that I have to face.
Right.
And so they're terrified. School becomes like this terrifying place. It's like they've associated it then with pain, and now they're associating it with I don't want to go back because I have a ton of work to do. And so there's a psychological block in returning to school, and that's something it's a very real issue, yes?
It sure is. So migraine headaches can be associated with anxiety and depression, and like any chronic pain disorder. The other thing that we don't talk about often is there's actually a fear of having a migraine. So a lot of our patients, complain about being anxious about having the migraine because when they have one, it's so disabling and painful.
Yeah.
And so that's another aspect that you have.
Yeah,
to
we call that pain behavior here, and it's a psychological because here's the breakdown of that and how we describe it. I can't because I have a headache. I can't because I'll get a headache. You see, so it's synonymous. I mean, they're tying into the fact that they don't want to take risks or go out and do things because they're afraid they're going to get a headache attack or they're having a headache. And so what happens is over time their world starts getting smaller and smaller and smaller until eventually they're smaller. There are very little things that they have outlets for to feel comfortable. Right. So, and that could be really problematic, like continuing to move forward. I mean, having some good momentum moving forward, that could be very problematic.
Right. It is, like you described, a vicious cycle. And so you have to figure out how to treat both aspects of it, not just the migraine itself, but also the other factors that limit their quality of life.
Absolutely. And we kind of touched on this a second ago, but do migraine headaches contribute? They contribute to the development of other comorbid disorders like anxiety and depression?
Yes, they do. So migraine headaches often can be associated with those as well.
When you live with pain for a while, I guess what happens is the outlook of life becomes a little grim. Mm-hmm. Becomes a little scary, and you're more worried about taking risks and trying new things out.
Yes.
Yeah. I mean, I can probably count on my fingers the amount of times I've had a headache in my life. And I think, one was obviously when you have congestion, right? When you have a congestion headache, it's awful stuff. You can't even sneeze, cough, laugh. I mean, because there's just a tremendous amount of pressure on your face. But I can imagine living like that.
Right. So when you have a sinus headache, it lasts a week or two, and then it's over. And usually it's not necessarily disabling. You can still go about your daily activities.
Oh, it's disabling for me. I'm a big sissy. I'm in bed. I can't get up. Oh, will you hand me the TV remote? My wife makes fun of me.
You sound like my husband.
And her grandmother makes fun of me. She's like, oh, gosh, this guy's going to be high maintenance when he's an old man. Because I'm like, can you hand me my shoes? I'm just out. But, I guess everybody has a different tolerance for pain. I mean, it just depends on who you are. And I don't know. For me, it's just more fun. I just want the TV remote. I don't want to get up.
Yeah, the difference is for migraine, it's recurrent. It happens again and again. And so, that's, we were talking about anxiety and depression and the fear of having a headache.
Yeah.
So all of that plays into it.
Well, what I think about is when somebody lives with pain, it's like associated. There's an association there with pain. When you experience something, like, a few years ago we went to Disney World, and my wife, my 2 daughters, and my son all had stomach bug. There's only one other daughter that was fine. And I'm like, okay, we're here, let's go. And they were having a hard time. They were like, nah, I was like, are you serious? We're here. We're at Disney World. Let's get out. Let's go to the park. I'm not feeling too great. And I was thinking to myself, this is like the happiest place on earth. I mean, we've been looking forward to this trip. And then we get there, but it can actually really affect, like when you feel lousy, you don't want to do anything. And so it doesn't matter where you are, but the association and how it ties into feeling so uncomfortable can, really have an effect on your outlook.
Yeah. The difficult thing, I think, is, migraine affects men, but it affects women more commonly. And so I think there's also a lot of guilt about missing school activities, not being there when, your kids are at birthday parties, so just there's a lot of anxiety and guilt that feeds into it, and that's very hard on women in particular. I mean, men as well, but, I think women.
Well, I mean, yeah, we typically, I think that, well, you have organic headaches. I mean, there are so many things that happen to any individual, but I think about, like, just the effect of, like, being a mom and, like, trying to run a household or so, or if it's coupled on top of, like, a menstrual cycle. But yeah, it can have a substantial effect on things. Do you see a lot of that? Is there a menstrual cycle headache that is migraine? It's like kind of a migraine?
Yeah, we call that menstrual migraine. So, some women will experience migraines around their menstrual cycle. And, if there's a particular pattern to it, then that can be treated in a particular way as well.
Yeah. But then that's something that you can almost, I mean, it must be a little, you can count on that then to come every month. Like you're, going to have a headache. It's going to be bad. Yeah, that would be kind of hard to live like that, But fortunately, neurologists and medicine can really facilitate and make things easier for people.
That is the hope, that we can help them manage their headaches better so they don't miss activities, that they can participate in their family's day-to-day life and not miss work as well.
Absolutely. My guest this hour, Dr. Garza from the Center for Neurology and Neurophysiology. More from her. We're going to take a quick break.
You're listening to the Therapy Hour with Rusty Lozano, brought to you by the Center for Biofeedback and Behavior Therapy in Addison, Texas.
Hi, welcome back. Our guest today is Dr. Garza from the Center for Neurology and Neurophysiology in Frisco, Texas. We're discussing migraine headaches. In the third segment, we covered occupational function and migraines. In this segment, I'd like to discuss treatment options. And so we've kind of talked a little about some of them, but one of the first is kind of more heavy hitting. And that's, the fact that technology is making life simpler. Computers and electronics are being used to improve the quality of life for so many. And one such medical procedure is the use of trigeminal stimulation. Are you familiar with this type of technology, Dr. Garza?
Yes, so neurostimulation is sort of one of the hot topics in medicine right now. It's being used for all sorts of pain disorders. For headache in particular, the common ways that it's used right now are patient-applied technologies. So trigeminal stimulation can be applied to the forehead to stimulate the supraorbital nerves, and that feeds back to the brainstem, the trigeminal ganglion, to help reduce the frequency of headaches. The same thing can be done for occipital nerve stimulation, vagal nerve stimulation, and in very intractable patients, deep brain stimulation or nerve deactivation procedures. So these vary in sort of the invasiveness. So you have, like I said, patient-applied devices that can be used, and then you have surgical procedures that
they surgically implant things in the brain and we've heard of deep brain stimulation, and we had a discussion before the show about deep brain stimulation. I know that they use it a lot for maybe depression, right?
Right. So deep brain stimulation is used for depression. For me in particular, we use it for Parkinson's patients and essential tremor patients when the tremors make it difficult for them to manage in their day-to-day life and medications aren't working.
How does that work? Have you ever actually used, adjusted somebody's... So what do you do?
You basically have a programmer, that you put a little device over the deep brain stimulator implant.
And you're pointing to your pectoralis, so on your chest. It's implanted there?
Yeah, like a little pacemaker.
Yeah.
And then it's wired up under the skin and then into the brain. And then you can change, the different parameters, how much stimulation they get, how fast is stimulation given.
So how does the sensor attach to the chest? Is it magnetic or?
You're talking about the programmer?
Yeah, the programmer.
No, it just lays over it.
Oh,
you
wow.
Just place it over it.
That's crazy. I can charge my iPhone watch with this little magnetic little diode that I put in back, and it just sits there and it'll charge it.
Uh-huh.
But it kind of sounds real similar.
Yeah, so you actually have, like I said, there's no magnet involved. You're just placing it over the pacemaker there.
And then it can communicate electronically with the system.
Yeah, we do that also. A similar technique is vagal nerve stimulation for epilepsy patients.
And then what? You just move a little sensor up or down, and you ask people how they're feeling?
Well, it looks like a little iPad.
Yeah.
For the vagal nerve stimulation. For the deep brain stimulation, it looks like your old Palm Pilots.
Oh, wow.
And you basically just, you change the parameters, and depending on what you're using it for, some patients can give you feedback immediately, especially like tremor and Parkinson's patients. You can see immediately if their tremors are better or not.
So could you make, theoretically, could you make somebody hysterically laugh?
No.
Or make them cry if you adjusted the sensor?
Well,
I mean, is it that effective?
When
affect the brain that well?
You're trying not to do that, of course.
Right.
You're trying to make sure that you're at the right level, in the right place, so that they're not having side effects to it.
Yeah.
And so that's why you adjust it up and down. And each person's different. You have to find the right parameters for each person. But, those type of techniques are still under study for headache in particular. But there's, a lot of hope that they can be used in patients that have intractable headaches. The majority of our patients can be treated with other non-invasive techniques. So medication treatment is probably, the biggest way that we treat patients right now. And we use both abortive treatment, so medications for headache relief to try to knock out the headache when they have it.
Mm-hmm.
We know the more effective the abortive medications are, the less likely the headaches are going to transform or become chronic. Chronic is when the headaches are more frequent. And then we have preventative medicines in patients that have typically more than 4 disabling headaches in a month. Then we'll use preventative medications. Those are medicines that are given, and actually you can use medications or supplements too, that they're taken on a daily basis to try to change the frequency and severity of the headaches. Now, those type of treatments take time. It doesn't happen on day one. You have to give them a good trial. Usually we say about 6 to 12 weeks, depending on the medication, to see if they're going to change the pattern of the headache. That's the long-term plan.
So that's how come it takes so long in between doctor visits, because a neurologist may start a treatment regimen and then they want to see the effect of the medication, see how it's working. Mm-hmm. So when you see your doctor every 6 months or 3 months, that's what we're doing is you're seeing how well the medications work on trial.
Right. And the best thing a patient can do is keep a diary. And there are lots of great apps for doing that now.
Are there really?
About technology. Yeah.
Oh, okay. So you recommend people keep a diary and there are apps that will help them?
Mm-hmm.
What kind of information are you looking for?
I'm looking to see how often they're having the headaches, how well the headache relief medicines are working. Are there any triggers? Doctors, we're kind of scientists at heart. We want to see data. So if you have 15 headaches in a month and we started treatment, we want to know in the next couple months, does that headache frequency get less? Are they cut down? Or if it's the same, we have to rethink our treatment, think of an alternative treatment. So the more information you can give us about the headache, the better. And then we know, hey, is this working, or we got to go a different route.
Most people are pretty diligent about keeping their diaries up?
It's sometimes hit and miss. I have some patients that are really good about keeping their diaries. The more it goes on, sometimes it gets harder. But, if you come into an appointment and you can't tell me if the headaches are any better or not, it makes it very difficult to know where to go. Do we continue the same medicine or treatment, or do we go in a different direction? That information is just very helpful. And plus, I think patients learn a lot about their headaches, too. I'm always surprised. I'll ask them, how often do you have a headache? And their response I'll get is, I have 2 or 3 headaches a month. Oftentimes they have more headaches than they realize. They actually only pay attention to the big ones. So you have to ask the question in different ways. How many days in the month do you have a headache? Oh, well, I have 15 days a month, but I only have 2 big headaches. Well, that makes a difference to me. That means that not only I'm not treating 2 headaches now, I'm really treating
just one. But maybe living with like a 2 or 3, they don't even consider a headache.
They don't even consider it.
But we're talking about like symptom free.
Mm-hmm.
Like, that's what you're asking.
That's what I'm asking, right?
And they're thinking like, the debilitating ones. Mm-hmm. So I see. That could be a little perplexing.
It can, and it just makes a difference because certain treatments, we haven't talked much about Botox. Botox is used for chronic migraine.
How does Botox work?
So Botox, as most people know, is used for wrinkles, right? So it relaxes the muscles. But we actually think it's not the only way that it works on chronic migraines, that the locations that we put the Botox are really closer to the nerves in the head and face. And for Botox, we use 31 injections typically, although that may vary, per protocols, to try to prevent chronic migraine headaches. But chronic migraine is headaches more than 15 days out of the month. That's where we saw a benefit. We didn't see it in patients that had less, 1 or 2 migraines a month. So that's why keeping track of all the headaches is important, because it may tell you what treatments will work better.
And that way you can adjust your medications accordingly. Do you also treat for psychological conditions, like if somebody's having a little bit of anxiety or depression, you can treat that as well?
Yes. We take that into consideration in what medications we might choose. So for preventative medicines, the classes that we use often are the blood pressure type medicines, antidepressant medicines, and anticonvulsant medicines. So those are the ones that are classically used. If someone has a little anxiety and depression, then we might choose one from one class. If they have a little high blood pressure, we might choose one for the blood pressure class. So knowing it, other details about the patient helps to determine which, medication or supplement might be more beneficial for them. But if there is contributing anxiety and depression, treating that generally helps.
What kind of supplements? You mentioned supplements.
Yeah, sometimes I'll use magnesium or riboflavin. These are things that are over the counter.
Kool-Aid? Riboflavin?
They show a good propensity. About half of patients will respond to them.
That's nice. So you kind of work with it's not all medicine. I mean, you'll look at fish oils and riboflavin, different supplements as well.
It can't be all medicine. As we talked about earlier, there are so many factors that contribute to migraine headaches, and it has to be a combination of things. It has to be lifestyle changes, medication treatments, as you talked about, biofeedback.
I was going to ask, can hypnosis, biofeedback, and other non-drug treatments help?
They do. Yeah, they all play a role. It's just kind of putting them together to get the best outcome for the patient.
Like stress management.
Yeah, yoga, meditation.
Yeah, because here the philosophy and the approach with biofeedback is teaching a person how to control their stress levels, because stress can actually flare up their symptoms.
Yeah,
and sometimes instead of going up on the meds, the doctor might recommend that they learn some breathing techniques to kind of help them feel more calm while they're on a treatment regimen, and so it kind of makes a nice adjunct. As far as non-drug treatment, something to help.
I definitely think that's true.
Yoga, taking a walk, being active.
I think, especially exercise, I know for me it helps with stress management. I feel better. I'm happier. I don't gripe at my kids as much. It just has an overall positive effect on your life. And, when you have migraine headaches and all those things are triggers, then adding that helps. It helps to reduce stress as a trigger. It helps to prevent headaches. And you get, as you mentioned, the good neurochemicals in your brain going.
Very good stuff. Well, Dr. Garza, I really want to thank you for being a guest on my show. Where can people find you?
Well, my practice is in Frisco, Texas. We're the Center for Neurology and Neurophysiology, and you can go to our website, www.cnntexas.com.
And we'll have that on our Facebook post. And is there a good phone number to reach you?
Our phone number is 214-494-4424.
Awesome. Well, you've been listening to The Therapy Hour. The music used on our show is distributed by Spotify, produced by Forrest Smithson, and it's his radio mix. This week's show is produced by myself, sponsored by the Center for Biofeedback and Behavior Therapy. Make sure to check out our website, onlinebiofeedback.com, and listen to the show and access any of our previous shows. You can also listen along on YouTube under Rusty Lozano. Follow us on Twitter, RUZTY777, and on Facebook, The Therapy Hour with Rusty Lozano. Well, thank you so much for joining us, and we are signing out. Have a good day.